We're going to be talking, my name's Gord Arbus, and this is Dr. James Owen. We work at St. Michael's Hospital, Unity Health in Toronto, and we're family physicians doing HIV primary care. So we're going to be speaking today on HIV 2023, PrEP, PEP, and other pearls. And we also have contributions from our other colleagues, Carolyn Gian, Charlie Giang, and Charlotte Hunter as well. Here are my disclosures and disclosures from Dr. Owen. And we have not received any financial external support for this program. So the objectives of today's talk are to describe an approach to using HIV prevention tools, PrEP and PEP, applicable to the clinical setting, describe steps to initial management of a patient with new HIV-positive serology, review common medications used in the initial HIV management, including common side effects and interactions. And the goal of today's talk is to be interactive, so there'll be lots of time at the end for discussion and questions as we go along as well. So this is who we are. We're family physicians in an academic family health team in downtown Toronto. So we're a large group of physicians. We have an HIV nurse, nurse practitioner, HIV pharmacist, access to physiotherapy, HIV dietitian, HIV social worker, addiction counselor. We have access to a dentist, income security support counselor, a linkage to care worker, access to psychology, psychiatry. So we're very fortunate that we have sort of a one-stop, multidisciplinary health team. We have walk-in capability. We have after-hours access, evening and weekends, and same-day access as well. Our focus is on equity, and we do a lot of QI initiatives, and we're scattered over 5 sites around downtown Toronto, and we serve about 1,500 HIV patients. I'll pass it on to James.
Okay. Hi, everybody. So it is very exciting, first off, I will say, for the two of us to be presenting to you in person. I have a lot more fun doing this in person than doing this virtually. And I want to go really low tech to start with by just show of hands. In the past, we've done Mentimeter and so on, but let's do show of hands. I'm just curious, so for those of you in the audience, do you have people living with HIV or at risk of HIV in your practice? If we could just do show of hands. Okay, not surprising, otherwise you probably wouldn't be here. Okay, show of hands, who has prescribed HIV pre-exposure prophylaxis or PrEP before? Okay, actually a decent number of hands, that's great. And I wanted to say as well, I recognize that Gord shared the sort of a description of the practice environment where we work in, and we recognize that we're very fortunate, I think, to have the interdisciplinary team that we have, which helps to support us with things like HIV care, PrEP, PEP, and so on. And we recognize that many people may not work in environments where you have those levels of support, so we'll try to touch on that at points during this presentation as well. Okay, last question. Have you prescribed HIV post-exposure prophylaxis before to your patients? Few folks. And has anyone done this, I'm curious, outside of the context of an emergency department? So just in your clinic at like a walk-in? Okay, I think that that's fantastic. There's still a few hands, that's great. One of the things, well, I'll get to this with HIV PEP, and I try to instill this in the residents and medical students that we're working with, is that you don't have to send your patient to the emergency department to get post-exposure prophylaxis. As long as your patient has a way of accessing medications, you can do it from your clinic environment. Okay, before we get started, and I know this is a huge room and we have microphones in the middle, but I just wanted to know, I'm comfortable if folks wanted to shout out any questions to start with. I'll repeat it into the mic. Are there any burning questions that you have for us that you want to make sure that we address in this presentation?
I did have one patient who came to me and said, I really want to go, I might have a high-risk lifestyle and I really want to go on pre-exposure prophylaxis and that sort of thing. I've always, when I've looked at the medications, I've kind of looked and said, okay, there are a few key side effects here that I really want to make sure you're at that level of risk that I'm not actually going to be harming you by putting you on this. So would love your perspective on just how big those side effects are, the level of risks that they pose, and also, I guess, the level of risk if we don't prescribe PrEP to folks who need it. So.
Okay, that's great, thanks. Yes, I will definitely touch on that. Over here. I'm okay if you want to shout it out as well. I can repeat if you, okay. Sorry, it's a huge room. I'm used to presenting in a smaller space.
I'm interested in learning a bit more about like the practice of initiating PrEP without having all the labs, and like if we are waiting to initiate for lab work. Like,
Gotcha.
Yeah.
Okay, so figuring out the timing with labs and stuff. Okay, I will try to touch on that. And if I don't, please flag that for me at the end and I will get back to it. And I see another question.
I'd also like to see if you can review on-demand use and whether or not that's as effective as daily use of PrEP.
For sure, I will definitely touch on that. Okay. All right, so some good questions to start, and we're going to try to save a good amount of time at the end of this presentation for questions as well. Hopefully, yeah, we'll have about 15 minutes, maybe 20 minutes at the end where we can take more questions from you folks. So we're going to go in an order of talking about HIV PrEP, briefly talking about PEP, and then we're going to talk about the newly diagnosed HIV positive patient with some key slides on each topic. So let's start off with HIV PrEP. Clearly all of you are familiar with HIV pre-exposure prophylaxis, but for those of you who don't know, HIV PrEP or pre-exposure prophylaxis is generally a very well-tolerated medication and option for our patients who are at high risk of HIV to essentially reduce their risk of contracting their HIV down to zero. A lot has been published on PrEP in the last number of years, from the early guidelines from the CDC, which have been updated a couple of times, to our Canadian guidelines in 2017, and then there have been some other articles as well. I really like, for those of you who haven't seen it, this recent article in the CMAJ from 2022, which kind of gives you a lot of the key points around PrEP, and kind of highlights the fact that we are probably not prescribing this enough to our high-risk patients, and puts into context, I think, some of the approaches and ways that you might sort of be able to provide this to folks and identify folks who are at risk. So we have that. There are also, as I said, the Canadian guidelines that were in the CMAJ in 2017. US guidelines, I think, updated most recently in 2021. CFP actually had an article in 2022. In Ontario, we have a resource, I think it's ontarioprep.ca, I think that's the website. And then I'm sure there are many others. I've seen a number of sort of regional guidelines as well. And you folks will have access to the PDF of these slides in the app, and hopefully all of the links are active. If they're not, feel free to contact us at the end if you want any links from us. So HIV PrEP, the indications are as follows, according to the 2022 article. So it's recommended for persons engaging in condomless anal or vaginal sex, either with partners of unknown HIV status or with partners with known transmissible HIV, aka a detectable or unknown viral load. And I don't think we have this specifically on a slide, but I really want to emphasize that if an HIV negative person is having sex with an HIV positive person with a consistently undetectable viral load, there is no risk of viral transmission. And in fact, in that context, if that is the only sort of sexual partner that HIV negative person has, PrEP is actually not indicated for that person because of the power of U equals U, aka undetectable equals untransmittable. So additional risk factors, according to the guidelines, such as previous use of HIV post-exposure prophylaxis and specific bacterial STIs are also useful in identifying people at elevated risk of HIV exposure. And there are some tools for risk stratification. Probably the most commonly known one is the HERE MSM questionnaire. In practice, I don't think that we use this ourselves that much, or maybe it's just kind of ingrained in my brain. So some of the HERE MSM questionnaire, for those of you who haven't seen it, kind of identifies some of the characteristics that may put someone at higher risk of, I think, what is considered to be sort of more intensive HIV prevention strategies. I really like what this CMAJ article has done, which kind of has a decision-making algorithm for you. I know it's probably too small to read in detail on the slide, but it's a bit of a decision-making algorithm to help identify where PrEP should definitely be prescribed, where PrEP could be discussed and then prescribed if requested, and then I think also sort of in situations where PrEP may not be indicated. So just to kind of talk through a couple of the pathways here, if someone has had anal or vaginal sex in the past 6 months, we're starting at the top of the algorithm. Let's say that they have one or more sexual partners of unknown HIV status. Ask about condom use. If condoms are always being used, then PrEP could be discussed and prescribed if requested. And I still have, I will say, a number of patients who say that they are consistently using condoms and they would still like to start PrEP. And for those who are kind of, very interested and motivated to do it, I actually personally have a fairly low barrier for prescribing PrEP, because I think that humans are humans. There is also a lot of anxiety around risk of HIV exposure for many folks if they are HIV negative. So I also think that PrEP can be a bit of an anxiety relieving technique. I also think about the fact that, for our patients, if you take a bit of a different analogy, our patients who are at risk of pregnancy, I guess, we talk about, condoms and the birth control pill at the same time, having two methods for reassurance that there is no risk of pregnancy. So I think about something similar with PrEP. So anyway, so this algorithm exists for indications for PrEP in the sexual context, and also for folks who are injecting drugs as well. So it's worth spending some time taking a look at those guidelines. Now, in terms of the different approaches to prescribing PrEP, again, I recognize there's a lot on this slide. Starting at the left, I would say by far and away the most common approach to prescribing PrEP is daily pre-exposure prophylaxis, which is essentially one pill taken every day. There is also the option of intermittent or on-demand PrEP. I'll talk about that in a second. When it comes to daily PrEP, there are two options. So there's tenofovir DF with emtricitabine, tenofovir disoproxil fumarate. This is the most commonly prescribed version of PrEP in our practice. It is the one that is typically covered now, I think, on most provincial formularies. In Ontario, for example, our patients who are on Ontario Works, Ontario Disability, or have the Trillium Drug Program, PrEP is covered for them. It's indicated. And it's got a generic available. So it's still an expensive medication. The generic form is about $250 a month in Canada versus about $900 for the branded version. It is generally quite well tolerated, I would say, by patients. I have a few patients with daily PrEP who experience a bit of stomach queasiness. That's probably the most common side effect that I hear about, which is usually fixed by taking it with food. I can only think about maybe one or two people in my practice who just really, for whatever reason, had difficulty tolerating taking daily PrEP. There's a possible mild impact on kidney function and bone density, which is almost always reversible upon discontinuation. So overall, very safe. The other form of PrEP is tenofovir alafenamide fumarate with emtricitabine, TAF-FTC. You'll notice that the dose of tenofovir in this pill is a lot lower because of the way that the molecule has been formulated. It is still quite effective for daily PrEP. It is equivalent to the TDF-FTC version. It's a smaller pill, more renal and bone friendly. But on the downside, I would say there's no generic available, so we're talking about a cost of around $900 a month if someone was to pay purely out of pocket. It cannot be used for the on-demand approach, which in my experience has caused confusion for a couple of my patients who've read about on-demand PrEP and then have just decided to switch themselves. That is not good, and I had to work with them around that. And the TAF-FTC formulation, at least in Ontario, is not covered on our provincial drug formulary. So it's really not an option as PrEP for our patients who are using that formulary. I'm not sure about other provinces, but I know in many cases it's not on the formulary. It's also a little bit less weight and lipid friendly as well. Now, in terms of intermittent or on-demand PrEP, sort of the 2-1-1 approach, for those of you who aren't familiar, basically it's the rule of twos. So 2 pills taken 2 to 24 hours before the beginning of the high-risk period, and then 1 pill daily for the duration of the high-risk period, to be continued until essentially 2 pills, 2 days worth of medication has been taken at the end of the high-risk period. So it's 2-1-1 plus kind of thing. So 2-1-1-1-1 until the high-risk period is over. This is definitely an option. I think it is still considered off-label prescribing here in Canada, though it is approved in the States. And it is only for gay and bisexual men who have sex with men and trans women. Those are the only populations where the evidence is there for on-demand PrEP. It is probably the most cost-efficient way to prescribe PrEP. It's got the lowest pill burden. It is non-inferior to daily PrEP. Although I will say, I have to admit, deep in my brain, I still think about my folks who are using PrEP very occasionally. They have occasional high-risk exposures. To me, the 2-1-1 feels a little bit risky because I do wonder if there's simply not enough medication. But the research has suggested that it is still quite effective. So it is an option. Although I have to admit that many of my patients still actually just prefer the daily approach. They have the peace of mind of knowing they've taken a pill daily no matter what. The other thing I would mention with intermittent PrEP is that there's more GI side effects with the 2-pill loading dose. So I've had a number of people start with on-demand. They get a really sort of kind of upset stomach kind of thing, and then we end up just switching them to daily PrEP, which kind of fixes things. So these are the approaches to sort of the PrEP medications. Now, just a few important points, kind of distilling the guidelines down to sort of the key things you need to know about prescribing PrEP. You must make sure that you document baseline HIV negativity at PrEP initiation and then follow-up testing every 3 months. So to the question about sort of blood work and essentially waiting for blood test results to come back, I think this, this can be sometimes a little bit tricky depending on how long it takes you to get an HIV serology result back. In some cases, I think especially during the pandemic, I think it would sometimes take us, a week or two to get our HIV test results back from public health. I think typically, if I know that someone is going to be starting PrEP and I guess I've ordered the blood work. I try to send myself a reminder in my EMR to make sure that sort of I've followed up with the patient as soon as that HIV test result comes back. And usually when I'm starting PrEP, I actually just kind of give the person the prescription, and assuming I trust my patient to follow my instructions, which I typically do, I say, don't fill this prescription until I call you and say that it's okay. So I get the result back, call them the same day, say you can start it. So you don't really have a big period of time between the time of the blood test and then starting the PrEP prescription. I have heard of some situations where folks have actually had access to point of care testing for HIV, which can be helpful if you, on the day that you write the prescription, you just kind of do a point of care test right away. That's nice if you have it, we do not. But yeah, I think usually I try to sort of minimize the gap between doing blood work and starting a PrEP prescription, and thus far haven't really run into any difficulties or challenges, which I'm happy about. And on the next slide, I think I'll show you the blood test that we would order, and if I'm ever under any doubt, if I've got someone who's got kind of consistent high-risk exposures on a really regular basis, I will sometimes choose to do an HIV serology test about a month in, just to capture, any sort of really potentially sort of recent exposures, and probably just reassure myself that the patient's HIV status is still negative. So other principles of prescribing PrEP, screen for other STIs as well as HIV every 3 months. Remember that these patients are by definition at high risk of STIs. Only prescribe 3 months of PrEP at a time. And I recognize that PrEP can be time intensive. So consider supports such as phone calls from the nurse, templated email reminders, standing orders, providing multiple copies of requisitions in advance. This does take a lot of time and a lot of work. And I think even within our group practice, I think it's fair to say, we find prescribing PrEP to, a number of patients to be quite challenging. So you do have to get a bit creative to make sure that you stay on top of all the testing and all the labs. As well as the prescribing, you want to make sure you counsel your patients around the importance of adherence to PrEP and adherence supports. side effects to PrEP. And again, to the question earlier, I think I find I will go through the side effects, the list of side effects with my patients, but I find that the vast majority of people do okay side effects wise with PrEP, so I do have a fairly low barrier. If someone really feels that they're at risk, and if I think that there is some risk of HIV acquisition on the part of my patient, I'm willing to prescribe it. And of course, if they do have any side effects, I just encourage them to follow up with me. In terms of non-PrEP specific counseling, I think it's fairly straightforward here. So at every visit, I try to take a brief sexual history, explore HIV risk reduction strategies, screen for STI symptoms, do substance use and mental health counseling where appropriate. And I'm always thinking about how I can do this in sort of a non-stigmatizing way. We've tried to automatically at all of our PrEP visits implement, whether it's with the nurse or the physician, screening for substance use and so on, but also recognizing that every 3 months, a series of questions about the patient's substance use may start to seem a bit repetitive and invasive. So we try to figure out how to kind of balance that while also screening appropriately. Here's the lab monitoring. I'm not going to spend a lot of time on this slide because I know that all of you can look it up in the guidelines. But just to emphasize that at baseline, you want to have HIV serology, a full STI panel. You want to make sure that you have your serum creatinine there, and then blood work generally every 3 months after that. All right, switching gears for a second. So now I'm going to talk about HIV post-exposure prophylaxis. This is something that I would say in the outpatient setting, Gord, I don't know about you, but it comes up on occasion, not super often, fortunately, and I think we're trying to do a good job of reaching our patients to get them on PrEP so that they don't end up in a situation where PEP is indicated. But this does pop up. This has come up often in the context of a patient comes to our Saturday or Sunday urgent care clinic. We might get a call from one of our colleagues saying this person is here saying they want PEP. I don't know what to do. So it's actually really not that difficult. And again, the big barrier is often just kind of figuring out how your patient is going to access the medications because they are so expensive. But this is something that you can prescribe to patients in the outpatient setting. HIV PEP, as I'm sure many of you know, is to be started within 72 hours of a potential HIV exposure. You have to do initial testing, which I'll show you in a second, and some post-PEP testing as well. But basically the bottom line is we know that for someone who has a potential exposure, if they start PEP within 72 hours of that exposure, they take the PEP for 28 days, that it will essentially reduce their risk of acquiring HIV down to 0. The regimens are here, so tenofovir DF with emtricitabine or FTC, which is generic PrEP, plus one of several other agents. Dolutegravir is probably the main one that we prescribe. And in the guidelines, there's a bit of a discussion about sort of pros and cons of different options, but by far and away, it's those first two, tenofovir DF with FTC with dolutegravir that you're going to prescribe to your patients. Now, a lot of time often needs to be spent at a PEP visit kind of gauging whether someone is actually at risk of HIV or not. I think there's understandably a lot of anxiety on the part of our patients if they have a potential exposure. It's really helpful to look at the guidelines and how they kind of break down the level of risk from different activities, which is the top part of the figure on the right. So substantial risk, low but non-zero risk, or negligible or none. And then the risk of HIV transmission by exposure type, high, moderate, or low. So of course the highest risk sexual activity is receptive anal intercourse. That is defined as high. If you look at the actual sort of point incidence of having, let's say, receptive anal sex with an HIV positive partner with a detectable viral load, it's somewhere around maybe 1 to 2% per act. So yes, it is a high risk thing, but it is, in absolute terms, it's not as high as many folks might think. Once you get to sort of the low risk activities, it's on the order of, you know, maybe 1 in 100, 1 in 1,000, actually 1 in 1,000, 1 in 10,000, that sort of thing. So very, very low is what we're talking about for the low risk activities on this list. PEP does require baseline testing, a whole bunch of tests that you would order at baseline, essentially HIV, your STIs, your Hep serologies, your ALT, your creatinine, and so on, and then follow-up testing at 2 and 4 weeks, and then your conclusive testing is at week 12. In practice, I would say if you're in an emergency department and someone comes to you requesting PEP, you can draw all of the baseline labs right then and there. If you are, let's say, at our Saturday urgent care clinic and you won't have access to the lab until Monday, I think that if there is enough risk that you think that the patient does need PEP, you can prescribe them PEP, and then you just need to follow up with your patient to get them their labs on Monday. Because frankly, you're not going to get your HIV results and all of these other results back anyway. So if there is a little bit of delay in getting your baseline labs, I personally think that that is okay. But if you are ever in any doubt as well, refer them to a setting where they can get their labs done right on the spot. These slides, when you get them, will have a number of resources available. We've got links in the slide set, so we've kind of interspersed that throughout. So we're going to switch gears. We're going to talk now about a new HIV diagnosis. I'll pass it over to Gord.
Thanks, James. Thank you. So now the question is, what do you do when you're, in your busy practice and you have a patient who's been tested for HIV, and either you've done the test or someone else has done the test, and they come see you? How many people right now feel comfortable in that situation, managing that patient? Okay, so not many. So that's why you're here, and hopefully what I'm going to tell you will be helpful in some way. So we're just going to start with a case. So this is the case of Janet, who's a 24-year-old cisgender woman. She performs sex work, and really there's inconsistent condom use in her work. She's on Ontario Works in Ontario, which is our provincial social assistance plan. And she has had STI testing about 9 months prior. And she talks about having sort of a recent flu-like illness a couple of months ago. And she had some STI testing done, and all bacterial STIs were negative. But unfortunately, an HIV test is done, and it comes back positive. So we contact her, and she's able to come back to clinic tomorrow. And sometimes it's even difficult to reach patients with these results, but we were able to reach her, and she was able to come back the following day. So I think it's really important that you take time to chat about the sort of initial reaction and have enough time in your practice to discuss what this means, what the implications are for this patient. So, and it can vary. Certain patients, it's like, I knew this, most of my community, most of my friends are HIV positive, so I'm okay with it. But sometimes it can be quite troubling and quite shocking to people. So you want to find out what supports they have. You need to have a discussion around disclosure to partners in terms of, what other partners were they with? Can they contact those partners? Do they need the assistance of public health? And really, you have to have a good discussion around ensuring that those partners, that they're disclosed. And then you have the discussion about who they feel comfortable disclosing their diagnosis to. And I have patients that I've known for many, many years who've never told anybody. No one in their family, no one in their community, because there's a lot of stigma. So you have to try and navigate that. You want to find out what their sort of concerns are psychologically, spiritually, culturally. Housing is a huge issue in most communities, and a lot of our patients don't have access to good housing, so trying to work through that. Supporting them through mental health and substance use concerns. Trying to find coverage for medication, because a lot of the patients won't have coverage, and so you have to try and help navigate that. And then you need to talk about, are you ready to start medication? Because everyone who is living with HIV should be offered treatment. And so today, with the treatments that we have available and from what we know about HIV and pathogenesis, everyone should be on treatment. So you need to kind of assess whether that patient understands that and whether they're psychologically ready and economically ready to start treatment. So this is from the DHHS guidelines, which are American guidelines that we generally refer to. So every patient with HIV entering into care should have a complete medical history, with a complete immunization history, a physical exam, and laboratory evaluation, and should be counseled regarding the implications of having HIV infection. And that discussion should include the benefits of antiretroviral therapy. So for that patient themselves, obviously, being on treatment will improve their quality of life, improve their prognosis, but also in terms of trying to prevent HIV transmission. And as James alluded to earlier, if someone is on treatment and their viral load is undetectable, they're not going to transmit their virus. So that's a very powerful notion and very motivating for patients to know that if they do take treatment, they're not going to pass their virus to somebody else. And then you need to talk about strategies to optimize their engagement in care and make sure that they're adhering to treatment. This is a big challenge, especially when a patient has mental health concerns or substance use. It's really difficult sometimes to engage them in care and keep them in care. So that's what keeps us all very busy. So the goals of the initial evaluation are to confirm the HIV diagnosis, and sometimes patients have had an HIV diagnosis from a point of care test or from another clinic, and we're in the habit of repeating that test just to ensure that it is indeed a positive test. You want to obtain the appropriate baseline history and laboratory data, and I'll talk about the lab investigation at baseline shortly. You want to make sure that they understand what their understanding is of having HIV and ensuring that they know how HIV is transmitted and how to prevent that transmission. And then initiate care as recommended in the guidelines, which I'll talk about shortly. So the baseline evaluations, again, HIV infection should be confirmed. And other tests that we do at baseline, I generally get in the habit of ordering these tests, but there are times when you have the patient in front of you that you're going to initiate antiretroviral therapy before you get the test results back. So it wouldn't necessarily preclude me from starting antiretroviral therapy, but more often than not, you're able to order these tests, these baseline tests, and wait for the results to come back before starting treatment if the patient's reliable and able to come back. But there are situations where the patient says, I want to start treatment today, please let me start treatment, and you can do the baseline evaluations and just start treatment right then and there. So in terms of the lab testing that we do, so you're going to, again, do the HIV antigen antibody testing just to confirm. You're going to order a CD4 count, which is a measure of their immune functioning. You're going to do plasma HIV RNA or viral load. And then you're going to do a CBC. You're going to do sugar, renal function, creatinine, liver enzymes, and bilirubin, a urinalysis. And you're going to do serology for hepatitis A, B, and C. You're going to do serum lipids because a lot of patients living with HIV will have abnormal lipids at baseline, and as well, some of the treatments that we use to manage HIV will have have increased lipids as part of their side effect profile. If you're going to consider a medicine called abacavir, you're going to order what's called an HLA-B5701 test, and if that test is positive, they're at high risk of developing a hypersensitivity reaction to that medication. So that's something that we generally order at baseline. And then based on what the viral load test result is, you're going to order a genotype, and this is basically a genotype resistance test to identify at baseline whether someone has genetic mutations that might create resistance for some of the medications you want to use. So ideally, you want to have that information at baseline because that might determine what medications you're going to prescribe. And generally, if the baseline viral load is less than 1,000, it may be difficult to get this test. So you generally have to have a viral load at baseline over 1,000 copies in order for the lab to be able to process that test. And then you're going to do other tests, including STI screening. Specifically, as James talked about earlier, you're going to do chlamydia and gonorrhea testing. Depending on the source, you'll do swabs, throat and rectal swabs for chlamydia and gonorrhea, and urine test as well. You're going to do syphilis testing. And then as the patient is part of your practice, you're going to do routine cancer screening as well. So starting HIV treatment, everyone should be initiated on antiretroviral treatment. So in 2023, every patient in your practice that is diagnosed should be offered treatment. But again, you have to make sure that that patient's ready to take treatment. You have to take into account the cost and what coverage, how the medicines are going to be covered. You want to make sure you have an understanding of their comorbidities. So for example, If they have coronary disease or cardiac disease, there's certain medications you might avoid. If they have renal failure, there's certain medications you will avoid. If they have hepatitis B, there's certain medications that you need to utilize that will have activity against HIV and hepatitis B. We have an HIV pharmacist, which is very helpful to manage drug interactions because some of the HIV medicines will interact with things like antidepressants, anti-seizure medications, pain medications. So it's really important to have an understanding of possible drug interactions. And then you need to sort of chat about childbearing potential and pregnancy because there are certain regimens that you would avoid in someone who is potentially going to get pregnant or is already pregnant. So again, you want to initiate treatment as soon as possible after diagnosis. Certain clinics will do what's called a rapid start, whereas if you have a patient in front of you, you're just going to get them started right away. And you order your tests, as I had indicated, and you still initiate treatment. I would say for us, that's a minority of cases because we generally have relationships with our patients. But if you're working in a clinic where you have someone in front of you and you think their follow-up isn't going to be good and you think they're at high risk, you might want to start them on treatment right away. Again, these are the tests that you are going to draw before you initiate the treatment. But treatment, again, in this rapid start situation might be started before the results are actually available. If you are going to do rapid start, there's certain agents that you're going to want to avoid because NNRTIs, for example, is a class where you might have a higher chance of having resistance. So you'd want to sort of know what your resistance pattern is before starting that class of medication. And again, if you don't have the result of an HLA B5701 test, I would not recommend starting abacavir in your rapid start. So the goals of HIV treatment are to maximally and durably suppress the viral load, restore and preserve immune functioning, or CD4 count. You want to reduce the morbidity associated with HIV, of course, and prolong survival. You want to help improve quality of life. And as well, you want to prevent HIV transmission. So these are kind of the reasons why you would start someone on antiretroviral treatment. And the advancement of HIV treatment, some of us have been doing this a while, and it's incredible. I don't think there's a field in medicine that's sort of been transformed as much as HIV medicine, even more than cancer care. So, in the 1980s and early 90s, the treatments were quite toxic. There were numerous medications. People were taking, 15 pills 3 times a day. And then in, sort of in the early 2000s, we got many more choices to use, and the standard of care now is a single tablet regimen. So generally it's 2 or 3 different molecules wrapped into one pill that someone just has to take 1 a day. And in the last couple of years, we also have an injectable option, which is basically 2 medications that are injected every 1 or every 2 months. So the injectable is sort of an exciting progress that's happened in the field. And probably in the next year or so, we're going to have another injectable treatment that will be given every 6 months. So you can imagine that for certain patients, that's quite a development where they could just come in twice a year and get their treatment. So the guidelines, again, this is from the US, American guidelines. There's different guidelines. We have Ontario guidelines, there's BC guidelines, but most people will refer to the DHHS guidelines in the US. And this is from September 2022. And basically, it comes down to a few regimens that are recommended. So the integrase inhibitor class, or INSTI, is become the sort of gold standard. And so most regimens are integrase inhibitor-based treatments plus 2 NRTIs. So you have bictegravir, FTC, TAF, which is Biktarvy, which is probably the most commonly prescribed HIV medication. So again, it's 1 pill once a day. Then you have another 1 pill daily option called Triumeq or dolutegravir, abacavir 3TC. Again, because it contains abacavir, you would want to make sure that the HLA test is negative. And then there's another regimen, dolutegravir plus TAF or TDF plus FTC or 3TC. So that would be a 2-drug regimen, 2-pill regimen. And then there's another option, which is a 2-pill single-tablet regimen, which is an integrase plus NRTI, or dolutegravir 3-TC. And in that regimen, which is called Dovato, or dolutegravir 3-TC, you would not want to use that regimen if someone had a high baseline viral load, if someone had hepatitis B, or if we wouldn't recommend that regimen in a rapid start where you didn't know what their resistance pattern was. So that's become another option with those caveats of when you would not prescribe it. So the coverage of antiretroviral medications, we're from Ontario, so most of our patients get covered through the provincial plan, but it's not like in BC or Saskatchewan or Alberta where everyone sort of gets coverage. But in Ontario, if they're on the ODB plan, so if they're on ODSP or welfare, they would get covered. The non-insured health benefits for registered First Nations Inuit, some patients will get covered through that. The Trillium program, which is in Ontario, if you have a chronic condition, you pay a deductible based on your income and the government pays the balance. Some patients, not many, have private insurance. Some get on a clinical trial in our practice. And some have to use the pharmaceutical companies through patient assistance programs, the Max card, for example, from Gilead or Vive Care. So you basically are at the mercy of the pharmaceutical company who do provide this treatment for a certain amount of time. So in Ontario, it's a bit of a hodgepodge. I know some people in the room are from BC or Saskatchewan or Alberta, where I believe it's a lot easier to access the medications, and in Quebec as well. So we sort of struggle, and I know in the Maritime provinces there's also challenges as well in terms of access. And then I was just mentioning the long-acting therapies. This has become sort of interesting for patients who say, I'm just tired of having to take pills, or feel the stigma of having to take a pill, where people are asking, why are you taking a pill every day? What's that for? So it helps to improve adherence, it alleviates pill fatigue, it reduces stigma. And so the uptake in our clinic is not huge, mainly because this drug came out during COVID and it was difficult to initiate sort of starting this treatment. As well, a lot of the patients I see are older and they're on multiple medications for multiple comorbidities, so there isn't a huge draw to kind of reducing their pill burden by one pill. But it is an option, and this is sort of the schedule. There's an optional oral lead-in, there's an initiation phase, and there's data to show that it's effective given every month, or now there's great data to show that you can give it every 2 months. And like I said, lenacapavir is coming, which will be kind of an exciting sort of every 6-month type regimen, which I think could be a bit of a game changer. So just back to our case, Janet's very surprised. She's upset by the results. You endeavor to reassure her that this is something that can be managed. I think it's very important for us to be upbeat about sort of the prognosis. You order the labs. You know that her previous hepatitis B serology is negative, her urine pregnancy test is negative. So you decide together to start bictegravir, emtricitabine, tenofovir, alafenamide, or Biktarvy, which is 1 pill once a day. And she has full coverage for that medication. And ideally, when you start antiretroviral therapies, I like to see people anywhere from sort of 2 to 6 weeks after, just to check in and make sure they're tolerating the regimen, make sure there's no concerns. And you come back, she comes back in 2 weeks. She has no problems. She's adhering to it. Her physical exam is within normal limits. Her baseline blood work shows that she has a relatively high viral load at 134,000. Her CD4 count is not too bad, mid-range at 754. And her other labs are normal. And the plan is to watch her very carefully and repeat the viral load in 4 to 6 weeks. So in terms of adverse effects, I think it's a game changer, the treatments we have today. They're totally well tolerated, much simpler to take. Like I said, most people are on a single tablet regimen, less toxic, better choices. The integrase inhibitor class is the most commonly prescribed. So you get some initial fatigue, you get some initial CNS effects like impact potentially on mood and sleep, but very mild. And you can get weight gain with some of these medications. So this is the thing that we're starting to see, especially in women, and especially in women of African descent. It seems to be more common where they're getting quite a bit of weight gain. So you need to do some counseling around nutrition and exercise. But it seems to have some implications for weight gain. Tenofovir has an impact, like was said earlier, on renal function and decreased bone density. The NNRTIs class, which aren't used as much, have some CNS effects and possible rash. The protease inhibitors, which we used to use a lot of, and thankfully most patients are not on protease inhibitors, have more side effects like weight gain, hyperlipidemia, impact on glucose tolerance. And abacavir, like I had said, has this risk of hypersensitivity reaction, so you want to just make sure that that HLA test that you're going to do is negative. And then there's a really excellent site from the University of Liverpool where it talks about drug interactions. And, it's an excellent resource, especially if you don't have an HIV pharmacist, where you just plug in the HIV drug, you plug in the comorbid medication, and it tells you whether there's a significant drug interaction or not. So this is something that I would definitely recommend if you could use this. So now we're just going to have time for questions and discussion. Before we do that, I just want to make sure that these are just some of the resource slides that we have. So there's some great OHTN, which is in Ontario, is excellent. There's PrEP and PEP guidelines and review articles that James had mentioned that on those links. CATIE is an excellent resource, Canadian HIV AIDS Treatment Information Exchange, Public Health Agency of Canada, DHHS, BC Centre for Excellence. And so that's just the CMH article that James was talking about earlier. This is the Ontario PrEP website. CATIE is there. PHAC, and I'll stop there because there's a good lineup of questions, which is great. Thank you.
Maybe front microphone, I guess, to start. Yeah.
Thank you so much for this talk. I'm wondering, for somebody who works in, say, urgent care, emergency, how would you reconcile, in like a non-judgmental way, talking about barrier use versus PrEP, or together? Because that usually tends to put people off.
Yeah. Do you want me to take this one?
Yeah, sure.
So it's a really good question, and I think, there's a recognition as well that, so obviously condoms and other barrier methods are very much a mainstay of STI prevention and HIV prevention, and when it comes to bacterial STI prevention, by far and away, condoms is the way to go. As a complete aside, there's also some limited evidence for doxycycline for bacterial STI prevention, different approaches, talk about that later. But yes, I think the way that I tend to phrase it to patients is there are a number of tools that we have in the toolbox that we can use to reduce your risk of HIV. Everything from, the number of sexual partners that you have, the frequency of your testing, to condom use, to PrEP, to PEP, to U equals U. I kind of just sort of lay it out to all of my patients. And then I find it helpful to kind of explore, because there is, within certain communities, I'm thinking about the gay and bi male communities, there's a lot more awareness of PrEP now. I mean, any gay man just has to log on to Instagram and they're bombarded with a whole bunch of like online PrEP prescribing ads, and all of their friends are on it if they're HIV negative. So, people know what PrEP is. So I have a conversation with my patients about that, and then really just try to kind of, with a shared decision-making approach, try to figure out what makes sense for them. And I also recognize with my patients that, I think humans are humans. To be honest, people don't like having sex with condoms if they feel that they don't have to. So I would say almost universally in my practice, if I prescribe PrEP, I find that my patients who were using condoms 100% or as close to 100% as a human can get, that rate starts to go down. And so I just acknowledge that from the upfront, to be honest. And I say, look, I think this does happen, and let's just acknowledge that. I'm not very good at being preachy, I guess.
No, but it's interesting because if people aren't using condoms, we're starting to see many more STI infections, and that's why it's really important to have them come in every 3 months.
Yeah.
Because you're seeing syphilis, you're seeing gonorrhea, you're seeing chlamydia, because they're much less likely to use condoms.
Yeah, and I've actually had some patients who, I guess, went through a phase where they were much more active, using condoms less, while they were on PrEP, and then started to get frustrated with the fact that they were getting so many STIs. They actually expressed to me their own frustration with the number of bacterial STIs that they're getting. They're like, I think I need to back off a little bit. So then having that conversation about what does that look like for that person. So that's my approach. Maybe we'll go to the microphone at the back next, and then I'll go back to the front. Yeah.
Hey, thanks for the helpful presentation. I was just hoping you could clarify what the current kind of policies are around duty to disclose as a provider if we know that our patients are not disclosing to partners when they're engaged in high risk of transmission activities.
Yeah, I mean, it's an interesting question, and it causes a lot of confusion. But, you know, the legal rulings are sort of in flux and changing, and such that we know now that if someone has an undetectable viral load, they're not going to transmit. And so I tell my patients, listen, if you're taking your treatment and we know that you're undetectable, there's no real requirement to disclose. Now, I still might say to that patient, like, I still just, to be sort of, you know, honest with someone, you might want to let them know about your HIV status, but there isn't really a legal requirement if your viral load is undetectable and you're taking your treatment and you're adherent. So I think that's very liberating for patients, but I still say, you know, listen, if you're in a relationship, it might be worthwhile to have that discussion, just because, you know, I've had experiences where patients have been in a long-standing relationship and then they kind of disclose their HIV much after the fact, and their partners are really upset and disappointed with them, right? Because it creates, like, why weren't you upfront with me? Why weren't you honest with me? So there's kind of two aspects of it, the legal aspect and the sort of relationship aspect. I don't know if that makes sense.
Yeah, I agree. I think about it, the different dimensions, the legal. There's also what your local public health unit, what their approach may be. And I would say in Ontario, we're working with many different health units, and I think that there's different approaches in the way that patients are counseled based on who is speaking to them from what region and their level of experience and comfort with counseling around HIV risk. So patients get a lot of different messages, and I think it's very stressful. So, but I do also just, as well as just kind of creating a culture of sort of, you know, destigmatization around HIV, I do encourage people, I try to empower them with all the literature around U equals U and all that stuff, and encourage them to disclose when they feel that they can, and certainly when they should as well. Up at the front.
Intermittent PrEP with women who have intermittent at-risk behaviors.
Mm-hmm.
Let's say, like, they go on a cruise once a year or had hedonism for a year, but then the intermittent, they're not going to be on PrEP for a whole year. So, and you said that it was only for the male gay population. So when would you start it? Like a month in advance? 2 weeks in advance? Never?
Gord, what do you do?
I mean, I like what you were saying earlier, I don't refuse PrEP if, you know, because sometimes what patients tell you is sort of 50% of what's actually happening. You know what I mean? Like, so I err on the side of providing PrEP and providing the opportunity for them to be on PrEP. I personally don't have a lot of intermittent PrEP use in my practice. But sometimes there's a cost consideration where someone says, like, A, I don't see my partner very often, and B, I can't afford to be on this thing every day, and C, I don't want to have the toxicity of being on this thing every day. So then I'm like, okay, if you're going to do intermittent PrEP, this is how you do it. Make sure you get the drug on board, you know, ahead of time, and make sure your tail is such that you're taking it, you know, for at least 2 days after.
Yeah. Well,
But I read somewhere that for women, it was not the
vaginal.
same.
Yeah, so I think, it's to do with penetration, as I understand it, into the vaginal tissues, that it takes more time. I have to admit, I don't have a lot of experience with this. The gender of my patients, predominantly by far and away male, but I think that if I extrapolate from sort of the daily PrEP approaches that we were using before intermittent PrEP was a thing, I think most people were saying at least 7 days.
Before it becomes efficient for women.
Yeah.
Okay.
So at least 7 days, kind of, we were saying that for everybody, so I would extrapolate that for women as well. So it's kind of, I don't do this very often, and certainly this isn't in any guideline, but I kind of have almost like a hybrid. I have a few patients who are doing like a hybrid between daily PrEP and intermittent, because let's say they're in the city, when they live here, they're not that active, so they don't need PrEP, but then they're going to go on a cruise or they're going to go away for the summer kind of thing, so I'll give them daily PrEP, started a week or two before they leave, taper, like they have a tail period of daily PrEP for a week or two when they're back, and I feel comfortable with that.
That was my question. Thank you very much.
Although it's not in the guidelines.
Yeah, it's
but-
very much not in the guidelines,
but,
so yeah,
yeah.
I want to recognize that.
Yeah.
Back microphone.
Hi there. I just have a question. So when you're initiating PrEP, so let's say you're having that initial visit, you get your initial HIV test, and it's negative, but knowing that it takes maybe somewhere 2 to maybe 6 weeks for that
Yeah.
test to turn positive, I just get like, how much should I worry if my spotty sense is kind of tingling, I get a repeat HIV test in a month, and that one turns up positive? Like how badly should I be freaking out, basically, in terms of their resistance to HIV active treatment?
Yeah, I would say, so you can kind of chase your tail, I guess, so only so far. And I share your same kind of anxiety, but I think, from what I remember, I think that the CDC guidelines said that they define someone as being HIV negative and eligible to start PrEP if on the, the advanced third generation test that we're using, if that was negative, and if in the last month they have not had any seroconversion symptoms. So basically the guidelines kind of said if both of those are true, your patient can start PrEP. I guess technically, again, there's that sort of, small risk that they've been recently exposed, which is why if I'm really concerned, I might do a 1-month serology in between. And obviously, if the patient gets any seroconversion symptoms, I ask them to let me know. That's my approach.
Thank you.
Great conversation. Question that might be a little bit out of guidelines, but I'd love to hear the language that you use. I work with higher risk people who are pregnant. So oftentimes trying to talk about or think about continuation of PrEP in pregnancy, but oftentimes initiation of PrEP in pregnancy because of repeated exposures, either due to sex trade work or intravenous drug use. How would you frame that to a pregnant person?
That's a really good question. Wow. Maybe it's unfair. I would want to actually turn that back to you and say, how do you do it? Because I have a few thoughts, but I don't actually do it that often. I think where my mind goes initially is I would just say, again, kind of like tools in the toolbox, right? I want you to be protected. These are all the tools that I have available to me, frequent testing, condoms, PrEP, and so on. And what are you comfortable with from the patient side of things?
It's helpful. Thank you.
Yeah. Back microphone.
Yeah, I figured it was fair game since you brought it up in the questions, but I was actually taking a step away from the HIV and going more to the DoxyPEP. I know it's not really kind of in any guidelines in Canada, and I was just wondering if you guys actually were doing that in your practice and what your thoughts were.
Are you? I'm doing a little bit.
Yeah, I mean, I think the data's there, the data's emerging, and I think the guidelines will reflect that very soon. So this is basically, in your patient that's very sexually active, having numerous STIs, I think it's natural that, using something like doxycycline, which will reduce the risk of STIs and syphilis. I think in the right patient, we're having those conversations. It's kind of limited because we're all kind of just sitting back, waiting. We end up doing things that aren't in guidelines anyways, but I think the evidence is emerging, so I would feel okay, and I do feel okay doing it in certain patients.
Yeah, in Ontario, there's this organization called the Gay Men's Sexual Health Alliance. They've been doing a lot of advocacy around DoxyPEP. I think if you Google GMSH, DoxyPEP, they've got some patient information handouts. I think they've got some provider stuff. We also have this organization, Rainbow Health Ontario, as well, and they've started doing, and I've seen the slides, they've done some presentations on DoxyPEP, and I think it's really fair and balanced because I guess recognizing that it could lead to quite an expansion of the amount of doxycycline that we're prescribing and risk of resistance and all that stuff. Evidence for and against, I think it's an interesting discussion. It could be an entire hour-long talk in and of itself, but I am doing it for a few folks. Yeah.
It's probably the hottest topic
Yeah.
in the field right now. Yeah.
Thank you.
At the front.
So if I understand clearly, if somebody used the condom 100% time, you can still prescribe the PrEP? Because in Ines, I think if they use the condom, it's like not an indication. But if he wants to.
Yeah, I think that 2022 article that I cited has a really interesting line which says something like, I'm paraphrasing here, there may be instances where you have a patient who is at very low risk of HIV acquisition, but based on shared decision making, you may still opt to prescribe PrEP outside of the algorithms that they show there. So that's what I think about, right? So my patient who comes in, they're like, I use condoms all the time, but I still I had one patient describe it to me that every time that they had sex, it was like there was this looming threat in the corner of the room that is this the time that I get exposed to HIV? There was a lot of anxiety wrapped up in that. And so, PrEP was as much an anxiety relieving medication for that patient. Really, they probably did not need it, but I felt comfortable prescribing in that case.
And for the women in the organigram, women with vaginal and more than one partner, you should talk about the PrEP. And I found it's a lot of people that I'm going to talk. PrEP.
Yeah, I think, I can't remember where that is in the algorithm, but I think if you're higher risk population, then certainly, if it's someone from a higher risk population, then yes, talk about PrEP. I would say your average, let's say, heterosexual woman with more than one partner, unless they have there's other risk factors for their partners, I probably wouldn't prescribe. But again, it's worth a conversation if someone's interested.
Okay, thank you.
Very quick last question, yeah.
Sorry. Just with PrEP, and we focused a lot on antibiotic resistance, has there been any thought as to how increased use of PrEP might contribute to, say, antiretroviral resistance by HIV, or not really yet?
I think there has been. Right?
Yeah, I mean, fortunately, there isn't a lot. I mean, there is that interesting question about, whether you're sort of giving PrEP to someone who's about to seroconvert, and then what's the implications for that. So that's a situation where, yes, you have a higher chance of having resistance to the components of PrEP and those mutations. But other than that, it's, generally we're not seeing a lot of nucleoside resistance to those medications. So far so good, but over time, as more use is being, you're going to ultimately see some more resistance. But so far so good.
No concern so far, is the bottom line.
Thanks.
Yeah. Thank you, everybody.
Thank you.
You have our contact information. We'll stick around afterwards. Thank you so much.
Thank you.